Good afternoon, everyone. This is Cha Orhalo speaking on behalf of UP Med Class 94 webinar team. This is an initiative of the University of the Philippines Medical Alumni Society. The UP Med webinar series is held every Wednesday from 12 noon to 1 p.m. Manila time. It delves on important current and emerging medical topics and is targeted for physicians, especially general practitioners, occupational and industrial health MDs, primary care physicians, family and community medicine physicians, and other health workers. Registration is free and this webinar runs on the UP Manila livestream platform at livestream.upm.edu.ph. If you have difficulties in accessing the webinar through the livestream page, please watch the Facebook Live video on our Facebook page. This session will run for an hour with 30 minutes allotted for lecture, followed by a question and answer portion, which will be moderated by Dr. Amy and Doug Silva. To participate in the webinar, please use the Q&A box found on the livestream page or by texting your questions to 0915-259-9686. And for Facebook Live participants, please type your questions in the comments box. May we now call on our moderator, Dr. Amy and Doug Silva, who is a member of the celebrating class of UPCM 1994 and is an associate professor of De La Salle University College of Medicine, where she is also the chief of the section of endocrinology.
Thank you, Charisse. Our time now in Manila is 12:04, and I am speaking from the video conferencing room of the University of the Philippines, Manila, IMS Padre Power Street, Ermita, Manila. Welcome to all our participants. Today's webinar is entitled Updates on Drug Therapy, Out with the Old, In with the New. The objectives of today's webinars are: review the epidemiology of diabetes in the Philippines, discuss the rationale for development of new drugs, discuss the profile of major drug classes, comparing the old versus new drugs, analyze the place of old versus new drug classes in the management of type 2 DM, and analyze the implications of the updates on practice guidelines. Today's speaker is my classmate, Professor Dr. Cecilia A. Jimeno. Dr. Jimeno is a member of the University of the Philippines College of Medicine class of 1994 and did her residency training in internal medicine and fellowship in endocrinology at the UP-PGH Department of Medicine. She is currently a professor and chair of the Department of Pharmacology and Toxicology, UP College of Medicine, and a clinical professor at the UP Philippine General Hospital, Department of Medicine, Section of Endocrinology, Diabetes, and Metabolism. She is a member of the Department of Health Formulary Executive Committee, a past president of the Philippine Society of Endocrinology, Diabetes, and Metabolism from 2013 to 2015, and is currently the vice editor of the Journal of the ASEAN Federation of Endocrine Societies. May we now call on Dr. Jimeno.
Thank you for the kind introduction, Amy. And Dr. Silva has already told you about the title of today's webinar. It really is just updates on drug therapy of type 2 diabetes, mostly in the outpatient. For a New Year topic, my question is it out with the old and in with the new? The learning objectives have already been said, and briefly it will be epidemiology first. Then let's talk about the reason why we need to develop new drugs and describe briefly the profile of the major drug classes, comparing the old versus the new. And then subsequently, let's analyze the place of the old versus the new drugs in the management of type 2 diabetes and what is the implication on the updates of the practice guidelines, especially the strong emphasis on the new drugs. Let's go first to the epidemiology of diabetes in the Philippines. We all know that we are top ranked in the world. We're top 15 for diabetes prevalence. This was based on the 2015 IDF data. We're top 8 for impaired glucose tolerance in the world. Diabetes is top 7 as a leading cause of death among Filipinos. And we have a 6% prevalence of diabetes in the Philippines. In a study that we did, this is actually closer to 7%. And these numbers then account for the 3.5 million adults who have diabetes, and practically half of them are undiagnosed. Of these persons with diabetes, in a survey that we did, only 15% are actually able to achieve the goal of an A1C of less than 7%. And the thing with the diabetes in the Philippines is that it is now number one as a cause of many complications. It's a number one cause of end-stage renal disease leading to dialysis. It's a number one cause of non-traumatic limb amputations, and is also the number one cause of adult blindness after cataracts. And I think it is also the number one cause of blindness in the adult working population. Very few Filipinos, as I said, achieve good sugar control. We have a horrendous 15% only who are able to achieve the target of less than 7%. And if you go down lower, it falls to around 11 or 10%. And therefore, given all of these numbers, we need to be more aggressive in finding our diabetic patients, in screening and diagnosis so that we find them and diagnose them earlier. But we also need to treat persons with diabetes better using both non-pharmacologic and pharmacologic approaches to achieve better sugar control and therefore prevent the complications like I talked about. But the reality, though, in the Philippines is that we have a very high cost of medications, even compared to our Asian or ASEAN counterparts. We have a limited number of medications available in the national formulary. And if you take a look at these drugs, they are the older drugs like metformin, glycoside, human insulin, for example. And because these are the drugs in the formulary, the DOH Medicines Access Program and PhilHealth can only fund and provide these medicines. And therefore, since these older drugs are the ones that are available, there is a lack of access of the poor or the disadvantaged to the newer medications. So are the old drugs really out? The older drugs, but they're still commonly used, are the following. It includes metformin, the sulfonylureas, human insulin. There are also actually other older drugs, but they're not that commonly used. So this include, for example, the glinides like repaglinide, the alpha-glucosidase inhibitors like acarbose, and the thiazolidinediones, for example, pioglitazone. Now, familiarizing ourselves with the new drugs, these include the incretin-based therapies, such as the GLP-1 agonists and mimetics, which are injectables. So an example of this is liraglutide, and the oral DPP-4 inhibitors, or the so-called gliptins, of which there are many. The other popular new drugs are the SGLT2 inhibitors, the gliflozins, and of course, the newer insulins, the so-called insulin or designer insulin analogs, such as the basal insulins, as enumerated, and the rapid-acting insulins. So what's the issue? Why do we need to talk about old versus new? Newer practice guidelines, which were released late last year, the ADA-EASD, for example, de-emphasize or hardly mention the older drugs that I have enumerated. Instead, they emphasize the use of the newer drugs, especially the GLP-1 agonists and the SGLT2 inhibitors. So again, going with the new drugs, why are they so in? The newer drugs have been proven by clinical trial data to have a positive effect on outcomes. This include the cardiovascular outcomes, CV disease and mortality, chronic kidney disease mitigation. They don't cause weight gain and in fact can cause significant weight loss. And there's almost no hypoglycemia because of their specific mechanisms of action. So the release of these randomized controlled trials has led to a change in the guideline recommendations. Now, I know that this is a very busy slide, but this is how exactly it looks like in the reference. So later on in the lecture and the webinar, I will give you the access, the website to be able to download this. But if you can see it, and I will just give you this smaller slide, or this much better slide, this shows you that although the older drug metformin is still up there, the newer agents like the SGLT2 inhibitors and the GLP-1 receptor agonists are the ones that are being emphasized, and I'll go to that later. So if I summarize, therefore, that very complicated colored slide, what it says is the older drug metformin is still first line for most persons with type 2 diabetes. So don't be afraid of the cheap metformin, which is readily accessible to many of our patients. No? This is the default drug for monotherapy unless there are contraindications to its use. And if you have to combine other drugs, combine it with metformin. So it's the base drug for combination therapy, unless, of course, it's contraindicated. Now, here is the mechanism of action of metformin. It improves insulin sensitivity and decreases the hepatic production of glucose, therefore lowering blood sugar. For familiarity, these are the available dosages. It's available as immediate release or extended release. And here are a few contraindications. So for many people, metformin is something that you can use unless you have already deterioration of renal function, metabolic acidosis, or even congestive heart failure, for example. It is very potent. It can lower down your blood sugar, an A1C drop of 1 to 2%. Now, metformin, again, is really cheap. It has low hypoglycemia potential. It's weight neutral, and for a few lucky ones, they can lose weight. And it has one of the best safety records among the oral anti-diabetic drugs. However, it is also common that it might cause gastrointestinal distress. So the idea is to start low and go slow so that you can mitigate this slight gastrointestinal distress. Very rarely, you can have lactic acidosis and vitamin B12 deficiency, which can be mitigated by the intake of vitamin B complexes or even calcium. Now, metformin in the past, maybe when our class were still the students, it has been traditionally contraindicated when your creatinine just goes up this high. Nowadays, metformin can now be given in the context or the setting of chronic kidney disease, where even if your estimated GFR is down to around 30 to 45, you can continue to give it. No? That's an eGFR which is much, much lower than what is shown by this creatinine level. And so for many people, it can be given unless your eGFR, your estimated glomerular filtration rate, is now down to less than 30. Then don't use metformin. If it's still at this range, you can still continue to use it. However, if the kidney function is expected to become unstable, then maybe you should hold off on the metformin. So just to summarize that part, metformin is still best. It's still first line, even if it's old and reliable. And when combination therapy is now indicated, after metformin has been given or at the beginning you have really very high sugars, then that's a time when you consider combination therapy with metformin. So metformin is the drug. Even if you forget everything I say today and just use metformin on most of your type 2 diabetics, you're probably correct. But after metformin, what do you add? Here is a guideline coming from the Canadian Diabetes Association, and it enumerates the patient characteristics and the agent characteristics, the drug characteristics, which you need to consider when prescribing after metformin. So for example, it depends on how high the blood sugar is. If the blood sugar is very high or your patient already shows some signs, for example, of rapid weight loss, maybe you should start insulin. Or if on the other hand, your patient is afraid of weight gain, maybe insulin should be avoided and we choose those which might make the patient lose weight. But the agents themselves must be considered because some agents have very high efficacy but have some adverse drug reactions like inducing hypoglycemia, effect on the weight, and certain other contraindications. Now, the other major consideration is actually the cost. This doesn't apply, of course, in the Philippines, but in other countries, for example, where insurance coverage is important, that's another consideration. And so what do the guidelines say here in the ADA, American Diabetes Association, and the European guideline that was released in October last year? It says the same thing. Consider patient preferences and important clinical characteristics. But what is being emphasized here as a first consideration among the clinical characteristics of patients is the presence of established ASCVD or atherosclerotic cardiovascular disease and other comorbidities such as heart failure or chronic kidney disease, as well as, again, the risk for specific adverse drug reactions, including, again, hypoglycemia and weight gain, and then, again, the tolerability and cost. So just to show you the summary of the guidelines, again, diet, exercise, weight control, physical activity, diabetes education is very important at the beginning and always throughout the life of someone with diabetes. You can start with metformin, but the next consideration after metformin is you first answer, does your patient have ASCVD, yes or no? And that will decide, therefore, what you choose. No? And if your patient has ASCVD, again, newer drugs are considered. If they don't, then you can choose from among the different choices, but as I will show you later, the preference is still actually the newer drugs, no? Like the incretin-based therapies, for example. So what is ASCVD? Very quickly, it's important. Why was that the first consideration after metformin? Because persons with diabetes die from ASCVD. It's the leading cause of death among people with type 2 diabetes. That's why it's the first consideration. ASCVD is defined as the following: whether you have established CVD, like you've had myocardial infarct, a heart attack, stroke, revascularization, and certain other related conditions with clinically significant atherosclerosis, including transient ischemic attack, hospitalized unstable angina, amputations, congestive heart failure, especially class 2 to 3, greater than 50% stenosis of any artery by imaging, symptomatic or asymptomatic coronary artery disease documented by imaging, and CKD with an estimated eGFR of less than 60. So you can see here that ASCVD is almost here in the definitions defined, no, along with ASCVD. So if you have CKD, you're high risk already for significant atherosclerosis, and so they're actually considered together. Now again, it says patient characteristics, drug characteristics need to be considered in prescribing. So after metformin, again, you decide, does the patient have ASCVD or CKD? If the patient doesn't have that, then the first line, as I said, is metformin. And if the A1C is above target, so these are people with an ASCVD. Like I said, the preference of the guidelines are the GLP-1 receptor agonists, liraglutide, for example, the injectables, and the gliflozins, the SGLT2 inhibitors. So even among people without established ASCVD, apparently the preference of the guidelines are the newer drugs. Then afterwards, if they're still above target, then you cross. If you prescribe this, then you prescribe the other one, the SGLT2 inhibitor. So when do the newer drugs come in this new practice guidelines? Practically at the bottom. So it says, if triple therapy is required and you've already used your newer drugs, the SGLT2 inhibitors or the GLP-1 receptor agonists, then maybe you can add a DPP-4 inhibitor if they're not using the injectables. And third line are the old drugs, the sulfonylurea, the thiazolidinediones, and basal insulin. So the only one that won among the older drugs is actually metformin. All the rest of the older drugs were at the bottom in the new practice guidelines. So again, the consideration here was if you wanted to minimize weight gain or promote weight loss, it says don't choose any of the older drugs. Now, if on the other hand, you want to minimize hypoglycemia, let's say your patient might be a bit older, maybe the eGFR is already lower, your patient might have had a history of having hypoglycemic episodes, or for example, is a poor eater, then again, after metformin, first line, the considerations once again are the newer drugs. These are the incretin-based drugs. These are the gliflozin. But one of them, the older drug, was actually included, the thiazolidinedione, pioglitazone. And if still above target after prescribing any of those, then you can just choose. You can just run down. So this one, then this one, then and then it's still on the rightmost, which means that if you read this guideline, you consider this last. Okay, so here, once again, and no mention of the other older drugs. Now, if you want to choose a glucose-lowering agent, and the cost is a major issue, and then for many of our patients, this is the major issue. After metformin, and you're still above target. What is above target? It's above 7, or it's 1.5% higher than your target. Let's say your target is to bring it down to 7.5. It's above 7.5, 1.5% above that. Then, since cost is a major issue or a consideration, that's when you choose the older drugs, the sulfonylureas or the thiazolidinediones. And if you prescribe one, you're still poorly controlled, then you can choose that other one. So it's like saying that if cost is the major issue and it's not the weight loss, it's not the safety, it's not, for example, hypoglycemia avoidance, that's when you choose the older drugs, SU or TZDs. And at the very bottom, that's when you decide on injectable therapy if you're still above target. So again, if you summarize this, metformin, as I said, is the first line. That's always correct. After metformin, you want to optimize control, and now you're considering combination therapy. What do you add? It depends on patient characteristics and drug-related factors. But with or without atherosclerotic vascular disease, though, the consensus appears to be that the second-line drugs are the incretin-based therapies, the gliptins, the injectable GLP-1 agonists, and the gliflozins. So, on the other hand, the older drugs are often the third option, and they're only considered or preferred when cost is a major consideration. But one of the things that we have to consider is that their setting internationally is different. We also consider that there are some drugs actually that we have in our market that are not there. Gliclazide, for example, is not available in the US. It's not US FDA registered. And therefore, when they mention sulfonylureas, they do mention gliclazide, but in many of the studies that were evaluated, gliclazide was not evaluated. And as I will show you later, not all the sulfonylureas are actually the bad guys. They're not all the same. Now, if we go then, I talked about when you don't have atherosclerotic cardiovascular disease, but when you do have this established atherosclerotic cardiovascular diseases or chronic kidney diseases, and if ASCVD predominates, the patient has had an MI, has CHF, etc., then you can either prescribe the GLP-1 receptor agonists, the injectables, or the gliflozins, the SGLT2 inhibitors with proven CVD benefit. That is, if the EGFR is still adequate. So typically 60 and above, you can still prescribe gliflozins. Actually, in some, even 45, you may still prescribe. No, but that's a consideration in prescribing the gliflozins. If heart failure or CKD, on the other hand, predominates, then the preference is the SGLT2 inhibitors with evidence of reducing heart failure and or mitigating CKD progression in cardiovascular outcome trials. And if that cannot be given or it's not tolerated, then that's when you consider the incretin-based therapies. Now, if you still are not controlled, you're still above target, then you cross. If you've given this, then you give the other one. And again, the ones that are older are at the bottom. So at the bottom there for SU and TZD, and SU here also at the bottom for those who have heart failure or CKD. And that's probably correct. They even took out already the TZDs for heart failure or CKD because it might not be indicated in the setting of heart failure. So is it in with the new? Yes, especially for those who have established ASCVD, heart attack, MI, heart failure, for example, peripheral arterial disease, maybe, but maybe not, and I'll tell you in a while why. Chronic kidney disease, and they'd like to lose weight or minimize hypoglycemia. Yes, in with the new. But at what cost? Of course, higher cost. The gliptins, the many gliptins in the Philippines, the branded ones are approximately 60 pesos. Of course, there are newer, cheaper ones, but probably still at 30 pesos per tablet. The GLP-1 agonists, which are one of the top choices in the practice guideline, is injectable. And it will cost you almost 10,000 per month. That doesn't include the needles. The SGLT2 inhibitors, approximately maybe 55 to 60 pesos per day. And aside from these, GLP-1 agonists, as I keep on saying, they're injectable. And they do have unique adverse drug reactions, which we always have to think about when we prescribe them. So for example, the GLP-1 agonists, nausea, vomiting during the first week of initiating the injection, it does happen. It's very common, but eventually they do develop tolerance. And it's also one of the reasons why they do lose a lot of weight. The SGLT2 inhibitors, they do cause genital infections. Very common to have genital pruritus. Some develop urinary tract infection. And the more uncommon adverse drug reactions, which have to be discussed with patients, are the development of fractures, peripheral fractures, even toe gangrene, and very rarely, even some signal of diabetic ketoacidosis. So in with the new, as I said, but be careful about prescribing and consider costs. Now, is it really out with the old? No, they're still reliable, but we need to choose within the drug class. Because in the practice guideline, it says cost is the major issue, but in fact, how different are the costs? So if you take a look at them, the most expensive, like I've shown you, are actually the preferred drugs. And the cheaper drugs, what it's saying, what the guidelines are saying, well, you consider them because they're cheaper. No, they're really a lot cheaper. But there is still some use for them. For example, the thiazolidinediones, they're not that popular anymore. They do cause some weight gain. They do cause water retention. So that's why you have to avoid them in congestive heart failure. But in the very recent randomized controlled trial where they looked at the thiazolidinediones, pioglitazone, and even the sulfonylureas, this was a study done in Italy enrolling more than 3,000 patients. They concluded the study early. They stopped early because their conclusion was that in terms of the incidence of cardiovascular events, it was similar with sulfonylureas and pioglitazone as add-on treatment to metformin compared to other drugs. And therefore, they're saying that these drugs are still very effective. They are, for the most part, safe. They may not prevent cardiovascular events, but they are safe in terms of not causing premature mortality in terms of cardiovascular events. Now, sulfonylureas are very much feared, and enumerated here are the different sulfonylureas. But if you take a look at this particular drug, gliclazide, and I'm highlighting it because it is available in most formularies, WHO, the Philippine National Formulary. And the reason why it's been included is because its efficacy and safety have been proven by a large clinical trial called the ADVANCE, which was done among mostly older patients with at least one other cardiovascular risk factor going on for 5 years. So even Filipinos were actually included in this clinical trial. And what did they see? They saw that it was very effective in that 80% of all patients, again, I said earlier, in our surveys, only 15% achieve control. Here in this study, 80% of patients achieve control with a low rate of hypoglycemia, which is always feared in some of this sulfonylurea. Where is the other evidence for gliclazide? You can see that in this meta-analysis, if you just take a look at mild hypoglycemia, comparing gliclazide to glimepiride, much, much lower. And if you take a look at severe hypoglycemia, you can see that if you compare gliclazide to the other sulfonylureas, glipizide, glibenclamide, glimepiride, it has almost nil severe hypoglycemia, and it is weight neutral. In the advanced study, there was hardly any weight gain. And in terms of cardiovascular safety, compared to the other drugs that were given in all of these other clinical trials, you can see the trend towards an increase in cardiovascular events. And in advance, using gliclazide, you can see that, in fact, it favors the use of gliclazide. So although it's not statistically significant, it just says that gliclazide is safe, even among this population of mostly older individuals who even have already one cardiovascular risk factor. So how about human insulin? Can we still use human insulin? Yes. In fact, this is a good reference to read, the WHO guideline on blood glucose control among adults with diabetes. It says that if, in fact, you use NPH or human intermediate acting insulin and compare it with newer insulins, the insulin analog Glargine or Detimir, there's no difference in control. But of course, the newer insulins would have less hypoglycemic potential compared to the older NPH insulin. But the body weight, also there's a difference. But the difference in body weight increase is very slight, around 1.26 kilogram more with NPH insulin compared with the newer insulins. Okay, now, again, the differences between the two is really the cost. The analogs are much more expensive than the human insulins. But if you read the practice guidelines, whether it's human insulin or analogs, they actually recommend, and this is for type 2 diabetes, to use the insulins much further in the disease process, maybe third or fourth line, due to the risk of hypoglycemia and weight gain. Okay, so again, the ADA consensus recommendation for injectables is to add in patients who need greater glucose lowering effect of an injectable medication. GLP-1 receptor agonists, they're preferred over insulin. But again, the reality is that they're very expensive. Now, for patients with extreme and symptomatic hyperglycemia, insulin is really still recommended, whether it is the older NPH insulin or the newer insulin analogs. Finally, the cost and access to newer medications and insulin remain important issues throughout the world. So this is also a statement coming off from those individuals who did develop that ADA-ASD guideline, where they said that, in fact, they prefer the newer agents. Cost and affordability are a major issue for decision-making. The sulfonylureas, the use of the less expensive agents such as metformin, sulfonylureas, and even human insulin remain effective options. It's like saying, of course, we prefer these drugs, but there should be no reason why we cannot control the blood sugar, because these newer agents are just because we cannot afford the newer agents. We have all of these older agents which are cheaper, which are actually effective. And if we know them well, so for example, sulfonylureas, maybe don't choose the older sulfonylureas, maybe choose the one that has better safety, then they remain to be effective options. So we prescribe them not just because they're cheap, but in fact, they're effective. And for some of the outcomes that we talk about, they're actually safe. So in the end, is it old drugs versus new drugs? For the old, we still should be using metformin, the sulfonylureaglycoside. There is clinical trial evidence on the use of pioglitazone, which has shown durability in terms of control. And human insulin is very effective, but of course, the newer insulin analogs show less hypoglycemia potential, but not that significantly different at the much lower doses. Now, among the newer drugs, because of the evidence of their efficacy for prevention of ASCVD, and as well for mitigation of chronic kidney disease, then we have these drugs that are available, the incretin-based therapies, the DPP-4 inhibitors, the GLP-1 agonists, injectables, and the gliflozins. And if you want to learn more, the references that take a picture of this, these are the references that I mainly use in preparing this slide. The WHO guidelines on blood glucose control among adults with diabetes, and the ADA-ASD practice guideline that was released in 2018. So thank you very much for listening to this webinar.
Thank you for that insightful lecture, Dr. Jimeno. We now have 280 individuals logged in through live streaming and 144 participants through Facebook Live, and we will give you time to enter your questions for Professor Jimeno. We would also like to thank today's sponsor, Survey Philippines. So now we are going to check the questions that we have. All right. Okay. Before we see all the questions, I would like to ask Dr. Jimeno, do your patients come to you with information regarding these medicines. One of the most common questions I always get is, does metformin cause kidney disease? So I hope we can teach our clinicians also how to answer that question.
Okay. So I'm not sure how that idea of why metformin causes chronic kidney disease came about. But I think the reason for that is because it used to be really the way we do things, that if your creatinine just elevated, like I said, 1.5, 1.8, we'd remove metformin. So patients got the idea that metformin is causing the renal problems. It's causing the kidney failure. And therefore, they shouldn't be taking metformin. But like I showed you, there's already much data that there's much information on the safety of metformin. You can continue to prescribe metformin at around an eGFR of 30 to 45. But if the kidney function is still unstable, maybe you need to hold off on it. But for the greater majority of the patients, even at the early parts of chronic kidney disease, maybe until is that CKD stage 3, you can continue to prescribe metformin. It is quite safe. So please, we assure you, even the fear of metabolic acidosis, that's very, very rare. So if you just don't give it among those who are already predisposed to develop metabolic acidosis because they're hypotensive, they're septic, maybe they have congestive heart failure, metformin is very, very safe.
Okay. Now, one of the more common diseases in the Philippines, and I guess worldwide, is dyslipidemia. So we give a lot of statins. So there's a question here, and this person would like to ask, does rosuvastatin medication, which we give for cholesterol control, does it cause diabetes?
Okay, that's a good question. It's been known that all the statins actually do cause a slight elevation of your blood sugar. So it doesn't really cause diabetes per se, but in a person who is already predisposed to develop diabetes, it does contribute to an elevation of your blood sugar. Now, if you're diabetic or you're already diabetic, you already have if you have high cholesterol and therefore you have to take the statins, is it going to be a problem if you take these statins? No, because you can mitigate the increase in the blood sugar by just adjusting the oral antidiabetics or your other antidiabetics. It's very easy to control. So the elevation in the blood sugar with the statins is very slight. You don't have to be afraid that you're actually inducing diabetes. But yes, correct. If you are prescribing these drugs among people without diabetes, yes, correct. Watch your sugars because they do really cause a slight elevation in your blood sugar.
Now, here's a question that was texted. The doctor would like to know what would be the best time to give metformin. Okay. Is it before meals, after meals? Do they have to wait 30 minutes after meals?
Okay. Generally, actually, the instruction is to take it with meals. So that can mean either they take it just before they eat or a few minutes after they eat. And the reason only because you do know that metformin, especially the IR metformin, the one that is immediately released, after you take it, especially when it's not film coated, it readily dissolves in your gastrointestinal, in your stomach, and then subsequently after it goes through your intestine, there is some gastrointestinal irritation. And therefore, the general idea is to take it with meals. So whether it's more simple for you to take it just before you eat anyway, since you're going to eat, or right after you eat, but typically, yes, within 30 minutes after eating. But the idea is that you need to have a full stomach proximate to the time that you take it.
Okay, we have two more questions on metformin. Will hunger pangs also result from metformin, or is it due to hypoglycemia?
Oh, that's difficult because hunger pangs are typically part of the syndrome complex of hypoglycemia, so it's hard to tell. Metformin typically does not cause hypoglycemia. That's one. What metformin can do actually is also to increase the gastrointestinal movement. Only because metformin does have a slight effect on increasing your GLP-1 levels, and the GLP-1s are important in the movement of our gut. So there are patients who do complain of gastric irritation. There are patients who complain even of diarrhea or hyperdefecation. But many of these gastrointestinal side effects with metformin are actually dose-related. And therefore, you can mitigate it by starting the dose of metformin slow, start low, go slow. And then over time, they do develop tolerance. Unless it's really the run-of-the-mill diarrhea. That's not very common, but it does happen. I've had some patients who did develop diarrhea and intolerance to metformin. So maybe those patients need to be on other drugs.
And they're asking, would you prescribe a proton pump inhibitor to counteract the GI side effects of metformin? Or what recommendations would you give?
Well, if your patient has gastrointestinal adverse drug reactions to metformin, the first thing I'd do is to check my dose. Second is I'd check how the patient is taking the metformin. And then if those strategies don't mitigate the gastrointestinal symptoms. So for example, I've lowered the dose, I've already instructed the patient how to take it correctly on full stomach and still continues, then maybe you can ask what particular brand they took, because the only difference between generic probably and the branded drugs are most of the branded drugs have film coating in the tablet. And so that sort of minimizes the gastric irritation. And then secondly, I'd probably change the drug and start the patient on an XR or an extended release. Yeah, which has really been shown to be dissolved more slowly, and thus mitigating the problem. So those are the things you can do. Look at the dose. Is it too high? Did I start the patient too high? Is the patient taking it correctly? What particular drug is the patient taking? Is it a branded generic, or is it really one of the originator brands? And maybe consider using the XR.
Now, if a patient comes to you with an A1C of 6.2, because I know some labs or some doctors would request for that, would you immediately prescribe the medicine, or how would you manage a case like this?
Okay. So if the sugar is just a little bit high, I'd probably motivate the patient to be more active. Some people have difficulty exercising. Ask them what their baseline is. If they spend a lot of time just sitting down, simple fixes like standing up at work, maybe being dropped off 1 block from the office, or if they if they take an elevator, maybe they can get off maybe 3 floors go below their office and take the stairs. So simple fixes like that will usually do the trick. And this is especially true among the elderly. If the blood sugar of the elderly is just a little bit high, our targets for the elderly are much higher than usual, especially the frail elders, then maybe we shouldn't push them to the much lower targets, because they can have really bad side effects sometimes from the medicines.
So we still have to emphasize the role of lifestyle changes.
Yeah, that's very important.
Don't forget that when your patients come back to you.
That's not something I talked about, but that was that's emphasized over and over again by the practice guidelines, that in fact just fixing just talking about lifestyle modification and better compliance with diet and their choices. That does help a lot for diabetes.
So there's a question here. Is the additional cardiac benefit of the new OADs due to their direct effect on the heart and not simply as a result of better glucose control? So I think it's like an effect independent of glycemic control.
Well, a lot of it can be explained by their mechanism of action, but what seems to be the consensus is it's apart from the glycemic control. And that's why we always say that, because some people, they already prescribe these drugs, and because you can mitigate, let's say, heart failure or CKD by adding these drugs to metformin, they're happy even if their A1C is still 8.5, because the cardiovascular benefits, for example, or the CKD benefits of these drugs might be apart from their glucose-lowering effect. Because if you take a look at them, they're not as potent as metformin. They're not even as potent as sulfonylureas. But they really are proven by clinical trial data to really improve cardiovascular outcome. So especially in terms of heart failure, that's where, in fact, these drugs have the best effect in preventing hospitalization from heart failure among persons with diabetes.
So it's important to prevent these complications,
Yeah.
but let's not forget the role of A1C as well. So sometimes it becomes a debate among doctors. When the cardio like to protect the heart or the nephron want to protect the kidneys, but let's not forget A1C control as well. Now, there are questions about the guidelines. So given that the latest guidelines generally advocate for using the newer agents first among patients who are currently on insulin therapy, would it be prudent to discontinue insulin and shift to the newer oral hypoglycemic medications?
Okay. And that's hard to answer only because it needs to be like what the guidelines say. It has the patient characteristics as well as the drug characteristics have to be considered. If this patient, for example, on whom we prescribe insulin is someone where you're not actually sure if it's type 2 diabetes because they're thin, they're losing a lot of weight, maybe you've admitted them for even episodes of hyperglycemic emergencies, maybe I'd hesitate to use insulin. But if, for example, you use insulin to tide them over a period where they had an infection or they had an acute event, so you had to give them insulin, and then eventually your insulin requirement was decreased to levels that are very minimal, maybe 20 units. Then those are the patients who probably are really good candidates for shifting to the new medications. So what we're saying is, if your patient is truly a person with type 2 diabetes, the greater majority of them can actually be on oral anti-diabetic agents on good combinations, 2 to 3 combinations now. But if they really need insulin, don't hesitate. There will really be patients who would require insulin, and that's typically the hesitation. They're afraid of the shots, the hypoglycemia, the monitoring. But if they really need it, they really need it.
And the trials were also conducted among patients with insulin treatment, right?
Yeah,
so
correct.
Don't be afraid to combine these agents with insulin. There's no need to choose between them.
Yeah, that's not something I probably emphasize, that it's not true anymore that, like, for example, when you're a student, insulin, you just prescribe all insulin. If you prescribe oral. Now the trend is to combine across.
Now, there was one comment regarding simple cases of diabetes. Do you think a majority of our patients would still be doing okay with metformin? Or do you see some inertia with our patients?
Okay.
So your comment regarding most of the referrals that you get.
Well, of course, because we're both endocrinologists, we get the bad patients.
You get the bad patients.
Yeah, but even if, and that's why we do have an advocacy of really informing everyone about diabetes, because we did a study here in PGH, one of my fellows at that time, and a graduate also of the College of Medicine, we did a study among newly diagnosed patients. And newly diagnosed type 2 diabetes, meaning they've just had diabetes for a year. Practically, if I remember right, 45% of them already had some form of kidney disease. They already had protein in their kidneys. 10% of them already had ECG changes. But the point is, we're getting them too late. So in the Philippines, they're not doing screening well enough to get them early enough so that it's easy to control them with metformin alone. Most of the patients we get, you cannot put them on metformin indefinitely. It should be that within 6 months after prescribing metformin or after first diagnosis, if you don't reach your targets, add another agent. And then if in another 3 to 6 months you don't reach your target, then add another drug. What frequently happens is, after we prescribing 2 drugs, we stayed there and we stayed there all the time without really reaching for our targets. Diabetes is really simple. You just need to know the A1Cs. The target blood sugar is an A1C less than 7 for most, blood pressure of less than or equal to 130/80 for most, and the cholesterol target of LDL should be 100 for most, and less than 70 for some, the ones who are high risk. So ABC siya. Except patients never hear that from us. So we should be telling them that all the time so they know their targets.
And you mentioned something about screening. Would you like to, again, remind everybody what are the screening guidelines for the Philippines? I think most people think, should we request for fasting blood sugar at age 25? So some caveats regarding the screening for type 2 diabetes in the Philippines.
While we're pushing more screening in the Philippines, it doesn't necessarily mean that we just screen indiscriminately. That's not going to be cost effective. The first round of screening in the Philippines is screening for risk factors. If you are 40 years old and above, yes, do routine screening. Ask for an FBS, ask for an A1C even. But if you're less than 40, look at other risk factors. If you're overweight or obese, if your blood pressure is high, your cholesterol is high, or you have a first-degree relative with diabetes, type 2 diabetes, you probably need to be screened. Even if you're 21 years old, if you're very overweight or you have, for example, obstructive sleep apnea, you snore when you sleep, you're sleepy all the time, your cholesterols are high, you probably need to be screened even at a young age. But here in the Philippines, routine screening using blood tests is at age 40. And there's a feeling that that age might even be lower. And we will publish data on that soon.
Okay, so 40 and up, get yourself screened. If you're younger than that, then please check your risk factors. Now, we were talking about diabetes. There's a question here. How about pre-diabetes and overweight? What would be the drugs that you would recommend for these patients? Or lifestyle? What would be your strategy for these patients?
Okay. If you logged on earlier, that was actually the webinar that was being test run earlier. So pre-diabetes, for the most part, can be managed by revising your diet, by lifestyle modification, by increasing physical activity, and there are recommendations on that. So we need to exercise at least 150 minutes per week. So that's around 30 minutes almost every day, or 1 hour every other day. And in terms of our caloric intake, we need to decrease the caloric intake to achieve weight loss of around 5 to 7% of your baseline weight. So if you can just do that, easier said than done, then yes, you can prevent pre-diabetes from becoming diabetes. Now, after you've done that, you're successful, and yet your sugars are stuck. That's the time you can try actually metformin. Even the other drugs that I mentioned, alpha-glucosidase inhibitor, acarbose, or even pioglitazone, there are clinical trials that have been done that have proven that they do work for diabetes prevention, except that these are drugs that are, of course, a little bit more expensive and harder to take. And that's why the recommendation for pharmacologic therapy, aside from drugs that can make you lose weight for pre-diabetes, is really metformin. So it's still metformin.
How about the newer drugs? Are there data and they're used for pre-diabetes or simply for weight loss?
So there is some data actually. Like if you really want to lose weight, the liraglutide, one of the GLP-1 agonists, if you give it at a much higher dose, it's actually already labeled for weight loss, even if you're not diabetic. So, but that's a little bit extreme for you to inject yourself with a drug that is commonly used for persons with diabetes for you to lose weight. Now, I think they're already running tests for the SGLT2 inhibitors, because now they are indicated for type 2 diabetes. And yes, my patients love them. Even if they have all the adverse drug reactions, what they want you to do, let's say they have genital pruritus, what they want me to do is to just help them get over the genital pruritus. And once it's better, they would like to be on the gliflozins because they do lose a lot of weight. But they're not yet indicated for pre-diabetes, not just yet.
So these usages would be off-label then?
Yeah.
Yes. So be
we're
careful. Yeah, we're not advocating it. And they're not approved for those indications.
Yeah.
So we're still waiting for some questions to kick in. But for the meantime, I'd like to summarize what we have been discussing. We know that there are a lot of new data and a lot of excitement with the newer drugs. But in the Philippines setting, where cost is always an issue, the older drugs are still important. And when you listen to lecturers coming from different parts of the world, think about the drugs that are available also in their country. For example, gliclazide is not available in the United States. And that's why most American speakers you listen to will really ban sulfonylureas and say how bad these classes of drugs are. But we know the data from the rest of the world that it is still useful and it's something our patients can afford. And of course, always individualize the treatment of our patients and involve them. If you noticed, when Professor Jimeno answered the questions, she always talked about asking the patients what their choices are. Are they willing to put up with the side effects in order to bring their sugar down? Or are they willing to spend a little more money? Or are they conscious about the cost of medicines? So it's always important to involve the patient in your decision making. So I think I'm going to wrap it up. We don't see any more questions coming in. And after this session, an email containing a survey link will be sent to you. After answering the survey, your certificates will be sent to you. Please answer the survey so we can access our webinar and address more of your preferences and give you materials from this session. Thank you so much for joining us. I know there are people who joined in the Philippines, in the United States, and even in Europe. Thank you for your time. We would also like to thank our sponsor again, Survey Philippines, for their support for this webinar. We hope to see you again in our upcoming webinar on January 23, Wednesday, 12 noon to 1 p.m. Manila time, with our speaker, Professor Emeritus Dr. Lulu Bravo, on the topic of New Year, time to debunk old vaccine myths. And this one is sponsored by MSD. Please invite your colleagues to join this continuing weekly CME webinar series. All webinar schedules and resources will be posted at this facebook.com UPMedWebinars. You may also email us at upmedwebinars2019@gmail.com for any inquiries. On behalf of UPCM Class 1994 and the UP Medical Alumni Society, we also thank our collaborator units, the UP College of Medicine Postgraduate Institute of Medicine, and the UP Manila Information Management Services, IMS. Ms. Charis, would you like to say your thanks? We'd like to thank you for joining us. This is Dr. Cecilia Jimeno and me, Dr. Amy Andag Silva, and the UP Medicine webinar team closing this session. We hope you have learned a lot from today's webinar. Join us again on January 23, and have a great weekend, everybody.